My name is Janet Selly, and I am originally from Boston. I am currently in Orlando, Florida, and I've been a cardiac nurse most of my over 30 years. In 2019, I had an opportunity to join a cardio-oncology program that was just starting with the use of some foundation funds, and it became a full-fledged program. We started with breast cancers, and now we are working with um, many different solid tumors and also lymphomas and leukemias. So it is definitely a growing subspecialty, and we appreciate that you're here today to learn about it. So, Chelsea?
Yes, good morning. Thank you again so much for the opportunity. My name is Chelsea Kreisberg, and I am a pediatric nurse practitioner with the Division of Cardiology. I am our team's cardio-oncology lead at Advocate Children's Hospital in Oakland, Illinois, just outside of Chicago. And I am currently the chair of the ICOS Pediatric Nursing Subcommittee. So I think part of understanding what we're here to talk to you about today is understanding what is cardio-oncology. Again, this is a relatively new and specialized field. It promotes identification and prevention of cardiac related risk associated with the detection, monitoring, and treatment of cardiovascular disease that occurs as a side effect of all cancer therapies. This includes the anthracyclines, also radiation, and other forms of cancer treatment. The goal is early identification of patients with cardiovascular complications related to their cancer treatments to ultimately improve the outcomes by initiation of appropriate and timely medical therapies.
Really, the first oncologic drug was nitrogen mustard back in 1946. But in the 60s and into the early 70s, we started to realize anthracyclines were primarily going to work for treating cancers. They were developed actually in a lab in Italy in the 60s. And what happened was we were successful with treating cancers. And then in the late 80s, early 90s, we started to realize that there was a percentage of patients that could potentially have cardiotoxicity based on these therapies. So patients were surviving the actual cancer treatments, and then we were having cardiotoxicity as a result of that. People were having congestive heart failure 10 or 15 years after their therapies. So that's where the actual subspecialty of cardio-oncology really started to develop. In 2009, Chelsea mentioned ICOS, and that's when the International Cardio-Oncology Society actually formed and created an actual house for this subspecialty to grow and flourish.
As Janet also mentioned, anthracyclines are a chemotherapy very, very frequently used for the treatment of many, many types of cancers. This includes leukemias, lymphomas, sarcomas, breast cancer, just to name a few. Anthracycline chemotherapy is associated with the highest risk of development of cardiomyopathy and heart failure in patients. Some of these anthracycline medications specifically are doxorubicin and daunorubicin. Another anthracycline is mitoxantrone. And while this is classified as an anthracycline, it is, however, a different mechanism of action. And when compared to its doxorubicin, has been found to be up to 10 times more cardiotoxic, specifically at a younger age of diagnosis. The mechanism of toxicity thought to be activation of a cell death pathway and inhibition of mitochondrial biogenesis, along with oxidative stress on the cardiac myocyte, is the primary mechanism of toxicity for anthracyclines. Again, these are used to treat many, many cancers and many blood disorders, specifically those leukemias that I mentioned, and do place patients at a very high risk for cardiotoxicity. That said, in addition to anthracyclines, cyclophosphamide, an alkylating agent, is used to slow or potentially stop cancer cell growth and may also have negative effects on cardiovascular system. Keeping all of this in mind, there is a medication that has been clinically shown to have some cardioprotective side effects. This medication is known as dexrazoxane or Zenocard, and you may have heard of this medication. It is often prescribed by the oncology team at the time of anthracycline infusion, and once, while thought to be controversial, related to the potentially increased risk for subsequent malignant neoplasms when compared to those who did not receive the drug, it has now demonstrated a reduction in relative heart failure risk by up to 43%. It's difficult to talk about cancer treatment without addressing radiation. Radiation exposure may further increase a patient's risk of cardiovascular disease. Key risk factors associated with radiation include the total cumulative dose received. This is oftentimes measured in something called gray. The irradiated cardiac volume, exposure to radiation at a young age, specifically those patients that are receiving radiation at less than 5 years of age, and when radiation is administered with chemotherapy. Also, if patients have previous history of cardiovascular disease, they are at a higher risk for CV-related cardiotoxicity if they receive radiation and anthracyclines. The severity or extent of radiation-induced cardiotoxicity is also associated with changes in the cellular composition, replication, and differentiation of radiation sensitivity. However, with all of that said, updates in technology to target necessary sites and to avoid others can lead to a decreased risk of cardiotoxic side effects. Specifically, when evaluating patients for radiation-related cardiotoxicity, a provider would need to strongly consider coronary artery disease, as this is the number one radiation-related cardiotoxic effect and affects up to 3.8% of pediatric cancer survivors. By the age of 50 years old, coronary artery disease in 20% of males exposed to greater than 35 gray of radiation, along with those patients who experienced increased exposure over time. Additional cardiotoxic diagnoses associated with and specific to radiation can include valve anomalies, heart failure secondary to the cardiomyopathy I already mentioned, arrhythmias, pericarditis, and thromboembolism.
Some of the actual side effects from the anthracyclines and from the radiation can last well after the patient has actually gone through their actual therapy. So it's important for patients to have the education needed to make sure that they appreciate some of the long-term side effects of receiving chemo or receiving radiation. Can last 10, 15, 20 years outside of when they actually have gotten their therapy. We just wanted to go over a case study that involves somebody receiving anthracyclines and actually HER2 therapy specifically, because that's another therapy that is something that we monitor and make sure that we watch echocardiograms for while they're getting their therapy. And if they do have a decrease in their heart function of 10% or a decrease in their global longitudinal strain on 3D echo of 8%, then we'll go ahead and monitor and get them in front of a cardiologist to get them on cardioprotective meds. So we have a 56-year-old female who was diagnosed in October of 2012 with ER/PR negative and HER2 positive breast cancer. She received an echocardiogram that was a 2D echo in December of 2014, and the EF on that echo was 50 to 55%. The NCCN guidelines currently say that anything that's below 53% for an EF developed is warranting more closer surveillance. And then in the realm of GLS, global longitudinal strain, if something is inversely lower than minus 17%, we will have to monitor those patients more closely. So what we did with this patient is in January of 2018, she had a strain echo. That's when we started our program with 3D and strain. And her EF was 62% and her GLS was minus 17.7. She continued on her HER2 therapy and everything was going well. And in June of 2018, she actually had a drop in her function. Her EF was 46% and her GLS was minus 16%. So that's when we were concerned. We reached out to the patient, got her referred to a cardiologist, and the cardiologist started her on a low dose of Corade, just a small dose of a beta blocker to help with cardioprotection. She continued getting monitored while she was getting her HER2 therapy. And the next echo that we got was EF of 55% and GLS of minus 20. So she did well. Every 3 months, we got an echocardiogram on her. In January of 2023, this past year, we had a decrease in heart function. And her EF was 56%, but her GLS went down to minus 17. So we called the patient, asked if she was symptomatic. She was complaining of just some shortness of breath on exertion. But then I realized after speaking with her that we delved into the issue more, and I wanted to, in the case study, ask what you think might have happened to cause the drop in the EF. Do you think she was started on a new regimen for Herceptin? That would be A. B would be, is the patient presenting with a progression of her breast cancer? Or C, did she run out of her Coreg prescription and not refill that? Or D, did she actually have an acute inferior wall MI? Go ahead. What do you think? What do you think the answer would be?
I was going to have to take a guess because having seen some of these patients and absolutely understanding where they're coming from, I would guess that this patient saw that her echoes had improved. She probably did, prior to this presentation in January that you mentioned, feel really good from a CV perspective. Maybe she had more energy, maybe her appetite had improved, maybe she was able to participate in some exercise that she hadn't been able to before. She was just feeling better. So my guess is that she ran out of her prescription Coreg, and because she was feeling so good, and because the data had shown that her cardiovascular function, or by echo at least, had normalized, she did not feel the need to refill it.
That's exactly right. So and she did just not refill her Coreg. So the takeaway from this case study is really to appreciate patients and meet them where they're at. Make sure that they have a clear understanding why they are actually on the medications that they're on. The real why for that. Because if they understand the why and they appreciate that, then they'll be a success in their own story. So what we ultimately did was we got her back in front of the cardiologist, got her resumed on her Coreg. And at this point in time, every 3 months when she gets her echo, I will send her a message and say, keep taking your Coreg. If it's low, refill it. We did have an increase in her EF again in the subsequent echoes once she started back on the Coreg. In July of 2023, she was back to 55% and minus 18.5. And then I'm happy to report that the October echo is actually even higher. So her EF is closer to the 70% mark, and her GLS is minus 20. So definitely is working, but we want to make sure that we really can give the patients a clear education and a clear understanding of why they are taking the medications they are taking so that they can be an active part in the success of the outcome. So over the years, we've been able to identify actually that oncology risk factors and cardiac risk factors, many of them overlap. Somebody that has hypertension, that is obese, somebody that has a history of coronary artery disease, if they actually develop cancer, they may actually have a higher risk factor just coming into the therapy. So that's an important piece to appreciate, and understanding where the patient actually is when they start their therapy is vital. The overlapping of the risk factors can actually prompt us to do closer monitoring. With my program at Advent Health in Orlando, we monitor patients every 3 months. Normally, we get an echocardiogram, and then during their therapies, we'll monitor them every 3 months with an echo to make sure that they don't have a decrease in their heart function. However, if somebody has cardiac risk factors that are overlying the cancer risk factors, that monitoring may increase to every 4 weeks or every 6 weeks based on those risk factors. So it's just important to appreciate that patients may have coronary artery disease before they actually come in to be treated for their cancer.
The screening is very, very important. Like you mentioned, hypertension. So what we have to do also is look at possible prevention strategies. So are these patients actively exercising? What's their diet like? Do they have a good relationship with their primary care provider or a survivorship team? Do they have regular annual scheduled follow-ups? Do they do maintenance screenings, for example, at the dentist? And all of these things should really be done screening before, during, and after cancer treatment. Hypertension, hyperlipidemia, diabetes, other things that can be used as possible prevention strategies when it comes to cardiotoxicity and cardiac-related side effects of cancer treatment include management and kind of supplementation with other things. For example, L-carnitine. Children treated with anthracyclines with abnormal stress echocardiograms had markedly lower serum carnitine concentrations in some preclinical studies. Specifically with doxorubicin, this was found to supplementation with carnitine was found to reduce cardiac-related mortality from 53% to 8% about 120 days after that takeaway and after that treatment. Anti-heart failure therapies can also be used to prevent further cardiac damage. And when I describe to patients and their families what to prevent or why it's important to prevent these things, is because you want to improve that function. If there is already a decrease, you want to improve it and you want to maintain it.
We want to make sure that we've got a good quality of life and the patient is able to enjoy their time after their therapies are complete. So some of the takeaway points we would like to share are patients are living longer. We're doing such a great job, not only with targeted therapies, with TKIs, with immunotherapies. We're really doing a great job with the success greater than 5 years, much greater than that, probably 15, 20 years. The actual data that had just come out is from ICOS was that in 2040, we're expected to have a projected survival of 26 million cancer patients. And because we are being able to do such targeted therapy and not treat patients with an overabundance of medication, but just the right dose for that right patient, that is a success. And we want to make sure that we prevent cardiovascular disease from being their demise.
Yeah, and along with that success, you want to consider the quality and the prolongation of an active, healthy life. The current estimated 5-year overall survival rate for childhood cancer survivors and AYA malignancies actually exceeds 80%, which is amazing. This translates to an increasing number of long-term cancer survivors, like you mentioned, and this is approaching almost 500,000 in the United States. In 2020, there was nearly 500,000 childhood cancer survivors, again, just in the US alone.
So I just want to make sure we've mentioned a lot about anthracyclines and also HER2 therapies, and it's pretty much out there that those are therapies that can cause congestive heart failure or potentially cause subclinical heart dysfunction. But keep in mind that some of the newer therapies, the TKI therapies and the immunotherapies, can not only cause some myocarditis in a small group of small population of patients, but long term, those patients can actually have plaque buildup, and cardiovascular disease is something that we need to watch for and monitor in those patients longer term once they complete their therapy, just to follow up. And it's really good and important for patients to share with their PCPs that they have had a history of lymphoma or breast cancer or whatever the case may be, and that certain medications and certain therapies had been given maybe 5, 10, or 15 years prior, so that the PCP can have a good, really a good base for how to treat that patient if they become symptomatic.
I absolutely agree. I think it's also really important to include any kind of radiation exposure in that conversation with the PCPs, their cardiologists, their survivorship teams, because that exposure to radiation may further increase that risk of cardiovascular disease, especially if in a breast cancer patient, for example, they receive thoracic radiation.
So cardio-oncology is a really, as we mentioned, rapidly growing subspecialty. We have many educational platforms that are out there and can learn from each other to help collaborate with each other as we go forward with all of the new medications that are being developed and all of the new therapies being developed for cancer treatments. We can collaborate in forums like ICOS and ACC to help each other learn how to best treat our patients and care for them with preventative measures to make sure that they don't succumb to heart disease as a result of chemo or immunotherapies or treatments for cancer.
The ICOS team offers up many, many, many virtual learning opportunities, collaborations, conferences, and on top of that, CardioSmart, which is a website, offers not only education for us as providers and nurse navigators, physicians, clinicians, but it also can offer up some support for patients.
The ICOS folks meet on Thursday mornings, usually from 9 to 10 a.m. Eastern Standard Time, to do a forum or a journal article review. And it's an international collaboration. It's a really good forum, really good platform.
Well, this is all that we have for you today. Thank you again so much to the PCNA for allowing us to speak to you. Thank you to my counterpart, Janet. It's always a pleasure working together.
Yes. Thank you again for just providing the platform to get the word out about cardio-oncology. Thank you very much.